So thank you, everybody, and thanks for the opportunity to talk to you this evening. So, as I said, I'm going to present a little bit and talk about a few of the principles and some of our experience in this area, and then I'd really welcome people's thoughts. And it's always good to think about other industry sectors and learning from elsewhere. So, disaster recovery and, importantly, business continuity in healthcare are topics that are very much top of mind for us. So we are a big acute teaching hospital. Those of you who may not be familiar with the geography, we've got about 2,000 hospital beds across our 3 sites in Leicester, and we employ about 17,000 staff. And just to give you an idea of scale of our IT estate, we've got about 12,000 PCs, laptops, and about another 7,000 or 8,000 mobile devices in the estate. So that's the sort of scale that we're talking about. So when we talk about losing access to some of that technology, it's quite a significant impact now. We are in a position where we are still very much paper-based as an organisation, and we are working on a digital transformation programme, have been for some years now, to remove that paper and move towards digital ways of working. And that, there's a number of aspects to that. It's about changing how we deliver healthcare. And if you've interacted with the NHS will know there is lots going on. There's the NHS app. There are various different remote monitoring and virtual ward type technologies being implemented across the whole of the health service. And that's, the technology helping us to manage demand as we progress forward. Population is aging. People have got more complex conditions than they've had previously. And medicine is advancing, which gives us capability to treat, but not necessarily capacity. So digital is a really important way of helping to address that, and us having the right foundations in place and building tools and technologies into our estate that can help our clinicians to work more efficiently when they're on site, and also help our patients to receive care in different ways. So thinking about things like, as I said, patient app is all a key pillar of our transformation objectives as an organisation. What that means is robust business continuity, and it's listed on the right-hand side there, is ever more important for us. So as we increase reliance on technology, we move away from folders. We are still, if you walk around our hospitals at the moment, you'll still see quite a few folders of paper notes and trolleys with paper in them being pushed around. And that's the way the NHS has functioned since its inception, really, in the 1940s. We are still working in that way in some bits of the hospital. In other bits, we are much more advanced now, and as we progress, we're seeking to be more comprehensively digital over the next 12, 18 months. We then introduce a different set of risks, a different set of challenges, both from a IT and a technology perspective, but also for our colleagues. So just some examples again of scale. So these are stats from our emergency department. They're currently generating, and they're partly on a digital solution at the minute. They're still generating about 25,000 pages of paper per week. So that's the kind of challenge we've got to continue removing paper from the organisation. What that means at the moment, they're operating in a hybrid approach. So we've got lots of old systems still. We are looking to remove those. We have a programme of work to reduce and remove those kind of green screen apps and move away from the paper towards mobile. We have platforms that we're progressing with that. And as we move from left to right and take the paper out and remove the folders and remove those thousands of pieces of paper out of our emergency department, what we're doing is we're introducing more risk, because even if we lose our IT systems at the moment in our emergency department, there is still a piece of paper that follows the paper around and patient around. And that effectively has become a bit of a comfort blanket for some of our teams. And what it means is loss of an IT system or loss of, whether it's a temporary outage, unplanned or a planned outage, is manageable. As we reduce and remove that paper, it becomes much more unmanageable. And some of the paper is clinically critical. So we've got, ECGs, for example, where at the moment we are still printing those bits of paper out and transporting them around the department. As we take those away, the risk increases. So what does it mean in terms of our thinking and our planning? So any outage of our critical systems has an impact, as it would do in any business. I suppose our impact is different. So we are in the same position as many others, I'm sure, that you would be thinking about in your own sector, prevention is better than managing impact of an outage and recovery. So have we got sufficient investment in our network, for example? Are we introducing and designing in redundancy and resilience? As we move to cloud, are we introducing diverse connectivity so that we're not dependent on single connections and we haven't got single points of failure? All very common principles that I'm sure everybody would recognise. But even then, the impact of taking a system down to do an upgrade or to having some kind of unintended interruption has a much bigger impact on our ability to deliver our healthcare services the more we digitise. So our business continuity needs to be viewed from all angles. It's not sufficient to say, oh, well, we've got two of everything, we've got two load balancers we can fail over. We know there are scenarios where that doesn't work, or it might have a bit of an interruption to service. And ultimately, lack of information on the front line, so our nurses and our doctors, is a patient safety risk. And that, you know, for us as providers of healthcare is really the critical factor in a lot of our thinking around the technology and the design work, and making sure that our infrastructure is as robust as possible. However, things do happen. So at the moment, this is just an example of the type of information that becomes unavailable. So this is an example of a drug chart. So if you put yourself in a hospital bed for a minute and imagine that you've been there a few hours, you've had a number of drugs prescribed, you've probably had some of them administered, hopefully, and then the system, which we've digitised several years ago now, we lose the network and that system becomes unavailable. All of that record of your medications that you've had administered to you today is now completely unavailable to the clinician. The clinician is probably looking after, is on a ward, maybe 24, 28 patients. In our emergency department, we can have several hundred patients in there at a time, all of whom are in different stages of treatment and care. So keeping track of everybody and logistics is one challenge, and retaining patient safety becomes really, really challenging, because as a doctor, your decision making around what you might prescribe to a patient is ultimately got to be significantly impacted by what drugs the patient's already on. We've got, you know, drugs that interact and cause issues. We've got allergies to consider. We've got the patient's various conditions that they've got to consider. And as a nurse, for example, then you've got a medication round to do, and you need to know, when did the patient last have their paracetamol? When did the patient last have that that medication that's been prescribed to them, so that we don't overlap and overdose patients. So that this type of information in an IT system is absolutely critical to the way we work. And as we move away from paper, we rely more and more as clinicians, they rely more and more on the IT system to prompt activity. So this patient needs another dose of that medication, this patient needs their observations taken. And the advent of a reverting to paper scenario means that we've got a whole set of challenges around how do we keep enough of that information somewhere visible to the clinician, so that they can almost revert back to their previous way of working and start to fill in something that looks a bit like this, which is a paper drug chart. And that's hard from a technology perspective, because that means we've got to create a document version of something, we've got to keep it in sync, we've got to put it somewhere that the individual user can access outside of their normal process, because potentially the normal system isn't available. If the entire network is unavailable, we've got to put it somewhere with local storage so that they can access it safely and access the right information for the right patient at the right time. And they've got to then be able to capture the information they would normally be entering onto the system on a piece of paper. And then you've got a whole recovery scenario to contend with. So it becomes really challenging, and the patient safety risks around an outage become really challenging. So I'll just talk briefly about a case study example. So this is something that from our organisation, this was an issue we had in December 2021. So we had a failure of a relatively minor network component. So it was an SFP, those of you who are technically minded. So very basic kind of connectivity component in one of our key network switches. And that caused a bigger impact than it should have done, because we had some issues with our networking equipment that didn't fail over in the way it could and should have done. What that meant is it resulted in a complete network outage across all three of our hospital sites for 6 to 8 hours. And what that meant for our staff was we lost all of our IT systems, we lost all our telephony, and we lost all our medical device connectivity. So in that scenario, were we prepared? Some of those digital workflows we've put in, because we are still hybrid, needed to revert to paper. And some of the issues we had very much more around human factors. So we realised we had doctors in the organisation who never prescribed on a paper drug chart since they'd started working with us. We had some who'd become very heavily reliant on digital ways of working, and actually it was a bit of an alien concept having to revert back to paper. So there's a real kind of training and education aspect. Did we have the right pieces of paper in the right format in the right locations around the hospital? No, we didn't. And that resulted in a whole series of challenges for our staff. And we had a really good response from the organisation to people coming in to help. So that's our IT colleagues and other people in different roles coming into the organisation to support and get extra bodies in to help. But we had, over the course of the outage, as I said, it was between 6 and 8 hours, we had 13 reported patient safety incidents. Fortunately, none of them had any harm identified. And in health, we do have a really rigorous post-incident investigation process, which was undertaken. So what that meant was we know exactly how many issues were reported and we know what the implications were. We followed all of that through to the end. And then a range of lessons were learned into preparedness and in terms of what we need to do from a technology point of view. There's a lot for us to think about in terms of how did something relatively minor cause such a major incident, but also what were the implications for having suitable business continuity processes in place for our staff, because it was clear from the write-up of the incident, the interviews that were conducted, that there was quite a lot of uncertainty and really inconsistent practice in terms of how well prepared different areas were. So our approach is a bit of a hybrid one. So we've got what we now have as a consequence of that investigation is we have boxes in all of our clinical areas which contain the relevant paperwork. So if the system goes down, we have the relevant paper versions of those data capture forms available for people so they can go and get them out and start writing on them. We have a number of tiers to this. So we have a web-based platform on which we can sync copies of PDF versions of those charts in real time with the live system. So if that system then drops off, we've got a relatively recent copy. And then we have laptops based out in the clinical areas, which mean they've got locally synced copies of those charts and an ability to do direct print. We are reviewing this at the moment because the more we increase the scope of our digital records, the harder that process becomes. So the idea you could go and print out everybody's record in any kind of sensible amount of time and distribute it around the organisation just becomes more and more untenable as the scope of the digital records increases. And asking the clinicians to prioritise what they need to be available and how do we protect access to it and ensure that we're still sticking to our information governance and cyber principles around only having access to what you need as a clinical member of staff is really important. And actually that becomes, again, even more challenging, exponentially more challenging with the volume of different bits of information that we've got held digitally. So what that means is it reinforces our approach that actually prevention is better than having to manage in this kind of scenario, but we do still need to have this kind of break glass. What happens if complete power outage, complete network outage kind of scenario? And some of the other things that we took from the lessons learned of the particular scenario I'm talking about were communication is key. So making sure people know. One of the high risks for us is that a group of staff decide that there's an IT outage and take it upon themselves to move to paper. And then we end up with a really messy kind of mixed economy scenario where some people are still using the IT system, some people are on paper, and who's controlling that and when do they switch back? And that, again, is introducing risk and clinical risk, which is what we're always trying to mitigate and minimise. So making sure you've got really clear lines of accountability and decision making through an incident is key. And we took some strong lessons from that outage incident where actually our managers on call and our kind of director on call process, they need to be really clear if there's a decision being made that we are in an outage situation. and we need to switch over. And then the recovery is really challenging. So having a few hours of outage where you revert back to old ways of working and you're writing on paper, actually then the cleanup is as risky and challenging as actually the outage period itself, because then you've got a digital record that reappears that's a number of hours out of date, and you've got stuff written on bits of paper that you've got to try and synchronize and align. So the size of the task of kind of coping with this sort of outage shouldn't be underestimated, and we're still in a lot of discussion as we progress with our plans around how we mitigate that suitably. And there is some best practice in this area. There's some big global systems that have been developed. We are in a position where we're developing our digital platform with our software supplier partnership. And we're sort of looking out for, well, what's the best practice that's been done? Where has this been done well? And the answer is, in very few places has it been done well, because it is a really challenging thing to do. We're going with this hybrid approach. We feel that's the best way, but we are at the moment looking at what other options have we got to almost provide parallel processes and parallel systems to mitigate some of that recovery challenge, because we're not careful, we create another whole industry and recovery problem, and it, as I said, introduce even more risk. The other point is around support, and it kind of goes without saying, but if you haven't got 24/7 support, you can't really start a conversation about recovering from a technology incident in the middle of the night. So making sure you've got the right expertise available. And the teams, from a hospital perspective, we're a 24/7, 365 days a year service, and we need all of our support services that are relevant in this type of scenario to be available at those times. And historically, I think we've been quite reliant on sort of goodwill and people going above and beyond to support. I'm going to stop there. It's a very short presentation, but I'm interested really to hear from industries about what their experiences are. Just to,
Andy, I know it's a little bit fuzzy just now. I mean, I think the network from your side, but I believe Andy has completed the presentation, right? Yeah. So
could you hear me okay? Okay, sorry.
Yeah, the network from your hand was behaving somehow, but I believe you've completed the presentation.
Yeah, so I was just saying, okay, that's the end of my slides, but I think I'd be keen to hear from people on their experiences in their own sectors and what people's experiences of coping.
Yeah. Oh, okay. So the floor is open because tonight we're going to make it a little bit very interactive. So there will be a section for Q&A. If you have any questions, any observation, anything you want to talk about, you can put it in the chat, or you can signify, then we give you the chance to talk. And apart from that, just like Andy mentioned, if you have any family experience you want to share based on what Andy said, any observation, I think the floor is open for us to contribute and giving our share tonight. Okay. Okay, so Amit is raising up his. You can use the icon to raise your hands. I could see the Azim Siga. So let me start with Azim, then I go to Amit. Okay.
Thank you, Kay. Can you guys hear me all right?
Yeah. In fact, Azim, we use this opportunity to welcome you I know we'll be having some email conversation. So you are welcome tonight.
Thank
Okay,
you.
so over to you.
Yeah, so Andy, thank you very much. That was very insightful. I wasn't aware of all the complexities and things like that around that the NHS side of things. So learned something new today. So the question I have from someone looking from an outside perspective is, has there not been any hospital, maybe not an NHS-based trust, maybe outside the NHS or maybe outside the UK, that has gone full digital and has maybe found a way to have disaster recovery in a way that you can still stay digital and it still works? Because I feel like trying to do disaster recovery by going back to paper, it's counter to, going digital basically. So is there not been a successful case in any hospital that's they've managed to do it at scale?
So I think, Azim, there's a variety of examples around in the UK and also just like in globally. You know, if you look at some of the more advanced hospitals over in the US, most hospitals in the US have been fully digital for quite some time. You can look at, there's a couple of hospitals in Australia, some of the Scandinavian countries got hospitals that are much more digitally, comprehensively digitally advanced than maybe in the NHS. What you find is there's a real mixture of approaches, and that's, I suppose, really the point I was making earlier. You know, there's some of the systems in use, particularly in the US, very much based on this kind of, well, there's a PC in the corner of each area that has got like a downloadable copy of something, and the challenge around, depending on the length of the outage, how do you keep capturing data clinically? Your IT systems may not be available. It depends on the type of outage, effectively. So you've got a kind of full, sorry. If that's all right, Rick, yeah, well, no, thank you. Sorry, just getting interrupted slightly. So what you tend to find is that the different vendors of the full sort of electronic health record solutions have got slightly different approaches to managing that process of the system being unavailable and needing to make sure that the record is still visible from that. But what happens is then you still got the gap. So if you had a network outage or a complete power outage, for example, you can have the best parallel system in place as a kind of business continuity solution. If you can't get access to it, you've got a problem. So what we've been looking at is, for example, having a cloud-hosted copy where we could fail over to a cloud-hosted service. So if we'd lost everything on site, what have we still got? So you almost need to take a step back. Well, if we've still got 4G, 5G coverage, unless it's got a battery in it with a 5G SIM in it, maybe there's a way of preserving access to systems. So I think cloud and kind of off-site hosting, compared with where we were, say, 5 years ago, gives us much more opportunity to do something different. But has anyone really cracked all of that with all the various different tiers of options? I don't think they have. I think there's various different combinations of those things. And that's what we're looking at, because we're in development rather than just buying something and go, well, we've got what we've got. It's causing us to, I suppose, challenge our supplier and say, look, give us some of the global best practice type stuff here. What does the evolution of the technology landscape offer us that it didn't offer us 5 years ago? And some of that kind of cloud, like the mobile network, probably one of those. And that type of thing, hopefully avoid just having to have paper forms and people writing off bits of paper, because it's, I think for us, it's that fragmentation of records that, as I said in the slides, it's almost as much of a risk as not having access to anything at all. It sounds odd because you think, well, surely you've got a version of it and you can start writing bits on the bottom, that's fine. But when you do that for 2,000 patients, and then you've got to try and piece it all back together again, it becomes really complex. So that's the challenge we've got, I suppose.
Thank you.
Azim, I believe that's already satisfy your questions.
Yeah, really. I was just looking for an insight and understand it. So thank you, Andy.
Okay, thank you very much. I think we'll move to Hamid. Hamid has a question. Hamid, over to you, please.
Thank you, Andy. I have a suggestion rather than a question or a consider or a potential solution that I want to run by you is that if you describe the problem very well, where there's an outage, network outage, for example, then you have a mismatch between also available on the mobile device and the paper. And going on to what Azim was saying as well, is it not possible to have your mobile device when there's a network outage, it stores the records on the mobile device, stores it offline. It's not connected, and then you can leave it there. And when the network comes back on, it pushes the record back on. And then if while the outage is on, and if you want to transfer data from one device to another device, you have a USB stick or some sort of memory card you can move around and pass it on to the other mobile device. It's the same as moving around paper, but I think it's digital. You see what I mean? So it's more. I'm coming from a solution perspective and using it as a sound, getting opinion on using this as a soundboard. So what are your opinions?
So more like having an offline. So you're talking like have an offline copy that you could then resync when the network comes back, that type of scenario. So you've got enough kind of data capture / or processing on your local device that you can then resync it when it comes back. Yeah. I think there are some examples of that. I think the challenge we've got, and this is the conversation we're having at the moment, is how much of the value of the I suppose I probably just need to give you a bit of context around what the systems do as well. So the system is workflow as well as data capture. So what if you're not careful, what you lose all of that workflow and visibility piece as well as the access to the patient record. So I think because we have looked at some of that idea around, well, actually, if I can just carry on amending what I've got and then somehow resync it, but it's complex. I think it's something we need to explore for the reasons you've described. It could be a better solution than having paper, because I think what I would like to see us do is not have any paper at all, and then you're then in a situation where you've got to have a business continuity solution that really shouldn't rely on paper, because you're just going back to, as I said, a process that nobody's comfortable with. But how you remove like almost all of the capability of the system and just give people a very basic kind of potentially just a sort of data capture form with some text boxes that you could type into, because that's the kind of thing you'd end up doing, I suspect. And then have that resync back into your core system, which has got all of the, all of that functionality in around clinical workflow and test results coming back in and triggering different alerts and things off, which is kind of what it does. It's just trying to identify what's that, and this is for the clinicians to do. What's the core bit of capability that they need to function at a very basic level to mitigate risk. So I think there's some mileage in what you've said, and that's the type of conversation we've certainly been having. But it is that real balance of how do you avoid going back to writing on bits of paper, but you've got to almost plan for the scenarios of what you have got to work with, and what you have got to work with. If you've just got a device with no connectivity, I think that's a step beyond where we are at the moment with the evolution of some of our platforms, to have almost like a fully functional local hosted copy of it, which is kind of what you'd need to some extent. But yeah, it's exactly the type of thinking that we're working through.
That's good. Thank you.
Okay, thank you. I myself, I have questions to ask, but before then, there are a couple of people in the chat. There is one from Wendy. Wendy has a question. Let me just read it. Can patients' record be on a cloud infrastructure, which could be out of the UK?
Yeah, thanks, Wendy. So we have to be careful about where we store patients' records from an NHS perspective. So we're subject to GDPR, and our sort of baseline really is that we don't want any of our patient or staff data traversing outside of the EU. So that gives us the ability to use cloud. So cloud isn't really a problem as long as you can restrict it to, if we're using Azure or something, we can restrict it to Microsoft UK data centers or even the European data centers. That's not really a problem. So if we had a provider, and we have had examples of this, if we have a software supplier who's offering us cloud hosting which is outside of Europe, that is the problem for us. But we can manage with, we can manage cloud infrastructure quite happily in the UK or Europe. Hopefully that makes sense.
Yeah, Wendy, I believe that you're satisfied with that. I go to Neil Crump. He has a question to ask.
Hi,
Neil,
Kate.
over to you, please.
Yeah, thanks for bringing me in. Andy, good to meet you virtually, that is. My name is Neil Crump. I work for Dudley Group Foundation Trust as Digital Strategy Director. Thanks for coming and spending time and just sharing your thoughts. First of all, it's a really complex problem, isn't it? Because first, you need to sort of see the difference between disaster recovery and then business continuity. I suppose my question is on the business continuity aspect of it. So what we're finding now, so to give a bit of context, Dudley Group have been using an EPR, electronic patient record, since about 2018, and we've gradually been putting more and more people onto that electronic patient record, different clinicians and operational staff. We're fairly mature at the moment. However, all of our infrastructure is still on premise. What we're finding is as we bring in new recruits, junior doctors who predominantly use a lot of this electronic patient record, they now don't actually know how to revert back to paper. So from a business continuity perspective, you then get into the difficult scenario of actually people who have never historically worked on paper because they are digitally native. So how do we solve that? Well, just to open up the floor, and then I could come back with a couple of thoughts as well, Andy.
Thanks, Neil. I think we've met on calls at various points. I'm sure I've seen you before somewhere. That's a really interesting point. I don't know if you caught the bit earlier when I said one of the issues we had in the network outage was that we did have a batch of junior doctors who never used a paper chart because this was their first placement. So they learned how to do it electronically, and no one had taught them how to write on the paper. So we've absolutely seen that, and I think again, for me, it steers us away from using paper as the business continuity solution, because you wouldn't give somebody you wouldn't give them a piece of technology that they hadn't been trained in to use. So why give them a piece of paper that they haven't been trained to use? We kind of need to operate on the same principles, don't we? It's not safe if they don't know how to use it properly. And I think what we then do instead is the challenge, isn't it? And we can vie for kind of 5, 6 nines availability of everything and work out how much that's going to cost. And then ultimately something that you haven't intended is going to happen, and the workmen outside the hospital go through the power cables. You've always got that risk to manage, haven't you? But I think for me, that planned versus unplanned point is important. And I didn't go into too much detail on that in the presentation earlier, but the planned outage, what we tend to see at the moment, because we are doing fairly regular updates to our system, and sometimes we need a 3 or 4 hour outage to update the database and that kind of thing. That's easier to manage because people can bring extra staff in, they can make sure the people on there are well briefed, they've got the box with all the business continuity stuff in it, and then they've got people who come in the next morning and do the transcribing back onto the IT system. That kind of works. When it happens and it's not planned, is very different. And I think we almost need to try and reduce the gap between what happens if there's a planned outage and our ability to respond if there's an unplanned outage as well. So some of that high availability, break out into the cloud, having devices on the ward that have got some kind of workaround connectivity in them. I heard talk of some of the security services work in London where they've got kind of SIM cards that can flip between mobile networks and almost give you that extra kind of preservation of opportunity to still connect to something. Those are the types of things I think across the NHS we need to be exploring, because they're opportunities we didn't have a few years ago. So I think, but yeah, I agree with you. It's the challenge around the workforce evolving, because you forget actually, sometimes it takes us so long to implement and change stuff in the NHS that actually the workforce can turn over quite quickly in terms of our doctors in training. So that's definitely one of the things we need to think more about. And it's about involving them. We involve them in the conversations, we involve them in the solution design and say, well, what are you comfortable with using and how can we help you to operate when, imagine the system's gone, your laptop switched off and your iPad doesn't work. What do you need to still look after your patients? And that, there's the types of conversations we're having.
Yeah, and we're due to move to the cloud in terms of our electronic patient record, probably October, November this year. However, as you all know, and perhaps some others who aren't in the NHS on the call don't know, is we have a very complex set of applications delivering patient care in the hospital. So it's not just solely the electronic patient record that is reliant for safe care. So even once we've then migrated our electronic patient record towards the end of the year, we're then going to have all of these integrated applications that will still be on premise. So I think we've probably got a multi-year journey, haven't we, in the NHS, where we're going to have to sort of transition that risk profile to better understand how we can do that business continuity. And it's going to be ever evolving over the next few years.
No, absolutely. And the more complex the infrastructure gets, it's like anything, isn't it? The more complex the infrastructure gets, the more interoperable everything becomes, which is part of our objective, really. So consolidating into fewer platforms is a key part of what we're trying to achieve, and it's going to take us a long time, but that is the intention. Because yeah, you're right. The integration between different bits of our ecosystem is makes that, if you lose one aspect of it, what else is still going to work or not? We've all got to take that into account as well. Thanks, Neil. That's really helpful.
Thank you.
To just bring people in because I can see the hands up.
Thank you very much. So while we alternate between the charts and the raising up of hands, so I think I will come back to the raising up of hand before we go back to the charts again. So the floor now is for Collins. Then after Collins, then Brian. Then before I go back to the charts. Is that all right? Thank you.
Go ahead.
Thanks, Kerry. Thanks, Andy. That was very interesting. I mean, I've been interested in NHS IT for over 30 years, I guess. You've used the words interoperability, and what you've described in terms of your business continuity and disaster recovery seems to relate to the local situation in your bailiwick in Leicester. I'm just wondering, on a kind of day-to-day operational basis, to what extent you interoperate with maybe national systems that NHS Digital holds, or other requirements to be interoperable with other providers, either of which might be having their own disasters that may impact on what you do at a particular point in time.
Yeah, absolutely. So it's probably a quirk of the NHS that maybe isn't evident to people who, you said you are au fait with the NHS, Colin, but maybe others aren't. The fact that we aren't one organisation. We are made up of hundreds of different organisations, all with local autonomy to decide what they want to do to some extent within some kind of standards and guidance boundaries. So yes, there are some nationally provided systems. So there is a what's called the national spine, which is where the sort of central record of patients' names, addresses, demographics is held. And we have some obligations to be in sync with that. But the way we need to plan, the way we have to plan, is that actually if we lose access to that, we still need a local systems to function. So you're right, we have to plan for some of that external interoperability, whether it's with the central NHS functions or whether it's with some of our local partners. So we've got our electronic health record that is used across our emergency department, has a view of the patient's GP record built into it, and it does an API call off to the national system that provides us with a summary of the patient's GP record. Really clinically valuable, but clearly if we lose our external connectivity, or if that central service goes down, or if there's a problem with the primary care solution had a cyber attack on it, you don't want the whole lot to come crashing down. We've got to have sufficient kind of, firewalls and security protection in place to be able to isolate ourselves. Because ultimately, my job is to make sure that our services on the hospital sites can still function. But we are more and more heavily interoperable and interdependent all the time. And, it doesn't take a lot for a cyber attack. Doesn't have to be in healthcare. We're all heavily connected into local authorities and local government as well. And, a cyber attack on one of those organisations could easily make its way through into our environment as well. So I suppose that's more for us about, as everybody needs to these days, remaining really vigilant, making sure you've got sufficient boundary protection, cybersecurity protection in place, and designing out the risk of something happening outside of your control that's going to take your own local capabilities out. So I suppose that's, in principle, that's how we'd look at it. But you're right, it is the more interoperable we get, the more things there are that can go wrong.
Thanks very much. Yeah. Yep. Thank you.
Thank you. Over to Brian.
Thanks. I just want to echo really some of what you said, Andy. I've worked in healthcare IT as a pharmacist for 25 years on the Wirral, and we've had electronic patient records on Wirral since I think the early 90s that I came in on. What I've learned in my experience over the years is like we've had a number of significant downtimes in that time, and they have become less frequent but more complex. So we're now on, I think we might be all, I'm not sure if we're all in the same system these days. It doesn't go down very often, but because it's all encompassing, so we have it in ED, critical care, we have it for prescribing, we have it for documentation, we have it for theatres. So when it fails, it's an enormous task to try and cope without it. Obviously, we focus so far in the conversation a lot on the technical side and whether or not, instead of reverting to paper, we could continue to capture things digitally, and that would probably be the panacea. But I think, as you said in your talk, a lot of it is around workflow. And when you have problems, especially unplanned problems, it's a case, in clinical areas like A&E and in theatre and critical care, you can't afford to be without your system for very long, or you can't afford not to be documenting. So you need good leadership, again, as you said, about when you go to downtime and how you manage it, so you don't end up with, kind of hybrid working arrangements. Again, you've mentioned the problem of like doctors not knowing how to go back to paper. That's across the whole spectrum, isn't it? Like nursing staff, pharmacy staff, whoever.
Yeah.
The recovery is so difficult, and it's almost, you have to manage it sometimes from a downtime to downtime basis, depending on how long you were down and the extent of it. We've often had to take a pragmatic approach. You can't recover everything. Obviously, prescribing for people who are still resident in hospital, you have to catch up with. But yeah, for people who've gone home, you may not have the capacity to do it. You guys are better briefed on the various technologies available. But the challenge sometimes is, when you're planning for an implementation, and even when you have a downtime, is trying to learn from it and trying to, see how you can better things in the future. There's always so many other competing pressures, and obviously competing pressures financially as well, in terms of, the investment in infrastructure needed, that seems to make it, difficult to come up with the ideal solution. But definitely interested in the discussion and how we can, come up with more digitally robust downtime solutions that we certainly don't have access to at the moment.
Yeah, no, recognise lots of that, Brian. Some really good points. But you're right. Yeah, it's one of the, I suppose, more generally, it's one of the challenges we have in digital health. We're all trying to solve problems from a slightly different starting position. And we need to really try and avoid reinventing the wheel if we can, but that's quite difficult because we've all got different constraints on investment and different bits of legacy and technical debt that we've got to address whilst trying to drive that transformation agenda forward. And I think, that's what makes, for me, that's what makes the job interesting. We're not just trying to keep the lights on and stand still. We're always trying to do that plus push forward, but it does become really challenging because you've got all of that kind of organizational change and people change aspect to try and contend with, as well as actually the advancements in technology, which we're all grappling with. So, you know, as I say, for me, it's what makes the job interesting, but it is also, yeah, it's quite relentless at times, isn't it?
Thank you. Thank you. I think we go back to the chat now. The next question should be from Stephen Booth. I know Stephen has a couple of questions, not just one, but even some contributions, so maybe want to share some things with us. So over to you, Stephen, please. Stephen? Okay, so while we wait for Stephen, probably is multitasking or doing something else. Can we go to Akpan Boniface? Okay, maybe I can read the question. So Boniface Akpan, the question from me, let me just read. What are the data protection challenges one must consider before implementing disaster recovery and business continuity in healthcare? And how can these challenges be mitigated? So let me put it in the chat for you to see.
So, okay. Yeah, I'm just trying to see what the question is there.
Yeah, I just put it in the chat for you.
Data protection challenges. So we do, yeah. So I suppose one of the challenges around some of what I've been describing is ensuring we don't end up breaking our usual controls around data protection and cyber. So if we switch to paper, people start writing stuff down on bits of paper and leaving them around on the ward when they're not. Again, it's back to what's custom and practice to some extent. That can introduce information risk as well as challenge for the staff. So that type of issue around, you know, how do we make sure that whatever our business continuity solution is, whether it's a technology-based solution or whether it's a paper-based solution or some combination of the two, how do we make sure we're still identifying people correctly? How do we make sure that we're still protecting that information wherever it is? So, you know, we can't have a set of principles, as I said earlier, around not hosting our solutions outside of the EU and then have a business continuity kind of downtime solution that's just entering data in free text over the internet with no security controls. We've got to have that same level of rigor around our cyber security and our IG protection as we would have in any other scenario. So I suppose it's about consistency and not, you know, finding ways of offering business continuity solutions to our colleagues without introducing additional risk, because what we're giving them isn't quite as good as what they would be using day to day. That's kind of how I would look at it. I think we don't necessarily, and if we stick to those principles, we're not necessarily then introducing more challenge. I think the challenge comes because of the mixed economy potentially with paper and with, you know, the what are the alternatives if you've got a downtime scenario? How do you protect? One of the issues we've had to work through is, and Neil might recognise this from his implementation as well, do you manage a scenario where you identify end users, you've got copies of data stored on an encrypted laptop, you've got to have some kind of break glass password approach so that they can log in and get access to the you store. So there was a load of challenge on that because then you can't audit who's got access to it, various passwords. You know, took it on a load where those sorts of scenarios introduced additional challenge around data protection and cybersecurity. But I think it's about navigating your existing principles.
No, the network is not the best at the moment. So what I'm going to do, Handy, just look at the chat. Why we ask Neil to come up with his questions. So after Neil prompt, then we go back to the chat again. So I'll put some questions in the chat for you, Andy, so you can just look at them and multitask while we attend to Neil. Over to you, Neil, please.
Yeah, just a thought actually, Andy. We're just about to sign with a modern clinical communication provider. So this is for non-urgent bleep. However, that solution actually provides kind of ability to connect and communicate and to sort of receive alerts, to have encrypted communications, to do some basic workflow and task management. I just putting it out there potentially as that could be a way of having business continuity in a digital way without having all the bells and whistles and integration with pharmacy and things like that that have been brought up on the call. However, it'd be another way of actually keeping the hospital running should there be an extended period of downtime. Just wondered whether or not you've got a sort of modern clinical communication system that is separate to your electronic patient record or not.
Yeah, so it's something we're looking at, Neil, in terms of how we do that. So for exactly the same reasons you've described, you know, we still do have some bleeps for that urgent use case at the moment, and I think it's a challenge. I think when, particularly in an outage scenario, you know, people have got phones, but do they know who to contact? And if their usual clinical workflow is kind of being defined within an IT system, so you know, I'm sending a referral from our emergency department to the orthopedic doctor on call, I don't necessarily know who that is. I haven't got their phone number. So I don't think we've quite solved that yet. I think there's still some questions for us around how we're going to manage those workflows, particularly in the downtime scenario. But I suppose our approach at the moment is that we've got the kind of platforms you'd expect. You know, we've got some use of WhatsApp, which is uncontrolled and ungoverned and not supported officially for us by for clinical use cases. And then we haven't got a specific plan around communications at the moment, other than the discussions we're having about, I suppose, inter-hospital referral type workflows within the EHR system. So that it's on our to-do list, I suppose, in terms of do we need anything additional, and if so, what's that capability going to offer us? But we're trying to build as much of that as we can into the EPR at the moment.
Yeah, I suspect, yeah, it's a good point about whether or not it should be in the EPR or not. Yeah, so I totally get your point about consolidating as many systems into the EPR as possible. That's exactly the journey we've done. For example, we've put maternity on and integrated that as part of our EPR. I suppose if we're looking for that disaster situation where you could actually have this other clinical comms solution in a separate cloud, that could be your backup. Because just say you've got
that's a good point.
We for example are going to put I'm just thinking on the hoof actually, because we've just put our EPR, or we're going to put it into Azure. But now I'm thinking, actually, we shouldn't be putting our modern clinical comms into Azure. We should be putting that into AWS or something, just to give us even more security.
Okay, thank you for that contribution. Is Andy still in the chat? Andy?
Yeah, I'm still here, Kay. Sorry, I'm just having a problem with my laptop, but I can still hear you.
Okay. Okay. So, thank you for that. So I think we can go over to Amit again. Amit, over to you.
Yes, I mean, what Neil and Andy were suggesting is about when there's a downtime, what is the functionality that you want to live with? So what is the core functionality? I think that the definition of that would really help, and I think it's probably very complicated, even the It's very complex, even the functionality that's required during the downtime, those are bare functionality that you need. And I think, so what I would say is that you can, once you define that, or if it's ongoing, then once you get most of the use cases defined, then you can have a fat client, and then you can use the database as just a data storage, and then the application layer will be very thin. So what you can do is that then have a solution where when there's a network outage, you can process data on your mobile device, and then work that way. But it's very opposite to the centralization that would happen, and that would be that's what that centralization that would be expected from most organizations. But I think it can work for the downtime scenario that you have discussed.
Yeah, you're right. I think it's that challenge of it's almost contrary to all of the other principles that we're trying to adopt, isn't it? So you end up with an even more complex challenge. I think the other point is the sheer volume of data as well. So it's not just number of patients, but you've got a local device. If you're syncing every single patient's data onto that device, that's quite challenging in terms of them being able to navigate around in it. And you'd have to have quite a robust sort of fat client type application to be able to control that and secure it effectively. So I think again, these are the types of conversations I think we need to have with the system vendors, because ultimately what we can put in solutions around the edges to fill gaps, but we're also quite constrained by what the vendors are offering in the health IT marketplace as well. And that, as I say, we're in a fortunate position, as I said earlier, because we are kind of working on a development project with a vendor. But a lot of the long-standing EHR solutions are very much you get what you're given, and you've got to try and work out whether you're happy with the level of risk. So yeah, it's some of those models around the sort of the briefcase approach and the local syncing get very complex very quickly. But it's certainly one of the options we've still got on the table.
Sure, that's good. Thank you.
Okay, thank you. I think we are getting there. Hamid, maybe you can put down that should be the legacy hand. So I think we can go back to the chat. So the question from Stephen, is Stephen there? Does he want to ask directly, or I should just read from the chat? Stephen, are you there, please? Okay, so Andy, can you see the questions in the chat from Stephen Booth? Stephen Booth? Hello, Andy.
I don't think I can. Okay, no, I only seem to be able to see the last couple of comments for some reason. So sorry, would you mind just reading it out for me?
Okay, I just put it now. I've put it again. Okay, but if you want me to read it, I can. Okay, so Stephen is saying a company I worked for in the late 90s had a product for 3-phase clinical trials based on a model of update.
Okay, yes, I think we've probably just covered a little bit of what Stephen's. But yeah, the point about making the digital look like paper is an interesting one. So, discussion with our clinicians about paper is the best way of doing it, and when you digitize the paper, you can end up with a big duplication of data entry, but also not advantage of the future opportunities. So I encourage that people not to do that in terms of the day-to-day usage of the development of the new system, because the paper is designed in a particular way because that's easier to fill in as a piece of paper. Some of the opportunities we've got to introduce different workflows and algorithms behind the scenes, and potentially AI type recommendations and clinical decision support in future. I think we're we end up constraining ourselves quite a bit if we sort of create a digital version of the paper form. Helps with familiarity, and it would certainly help with that challenge we discussed earlier about the doctor that's never done a paper version of the form before. I suppose it's the reverse engineering, isn't it? Saying, let's not digitize the paper, let's create a paper version of the digital form in that same format. So there might well be some mileage in that. So that's an interesting thought, actually, in terms of having paper forms that align with what the clinician is used to in terms of the new systems that we're introducing, rather than reverting back to sort of pre-digital versions of forms that they've never seen. I think that's probably a good thought to take forward.
Okay, thank you. There's another question on cyber attack. Andy, there is another question on cyber attack using backdoors. Did you see that?
Not see that one either. Next, sorry, could you just repaste it?
Okay, so it says there's a number of cyber attacks on the NHS that use backdoors in embedded devices that often use older long service releases of Windows.
Yeah.
Often these were old patch levels due to system being busy, so getting down to patch is hard. How does this affect or factor into your business continuity planning?
Yeah, so the level of risk we carry in the NHS around that type of technical debt, I think, was well publicised when we had the WannaCry malware a few years ago. That one of the reasons the NHS was badly hit is because of the dependencies we had still on at the time, Windows XP and Windows 7. I think we're in a much better place as a whole NHS now than we were then, and there's much more visibility of where that risk is. And we've got, certainly in our organisation, we have got some very old devices. Usually it's the devices, as the questioner said, that's kind of where it's embedded into a medical device. So our ability to just sort of take the PC aspect of it out and upgrade it can be quite limited, because ultimately the medical device vendors aren't necessarily that inclined to upgrade in the pace that we would want them to. So they tend to stick with sort of long-term releases of operating systems, and then we get constrained by that. I think we've got an approach where we put protection around those. So there's various ways of protecting and isolating in terms of virtual networking and protecting yourself against anything that did happen to that device sort of getting out onto the main network. But I think ultimately there's a set of standards that are in place that not all of those vendors are compliant with, and it does result in us carrying a set of residual risks that could well be the reason why we trigger a disaster recovery and business continuity scenario. So I think every year, often the other point around that is some of those medical devices, some of that medical equipment is very, very expensive to replace. So when we're operating with constrained budgets, if you've got a big kind of MRI scanner or something that's got an embedded Windows 7 PC, you almost, if the device vendor's telling you, well, you've got to replace the whole thing, it's going to cost you 12 million. That's more expensive than replacing a PC. So you're probably going to have to wait until the refresh cycle on the medical equipment comes around, rather than being able to manage the refresh cycle on the IT equipment. So the fact that our need to keep on top of our cyber obligations requires us to refresh and replace equipment much more frequently than maybe some of the medical kit that's got embedded PCs and sort of long-term releases of old versions of Windows. That's an ongoing challenge, and what we do have now is much better tooling to monitor and sort of protect ourselves against some of that. But it is, it's a case of isolate and lock down as much as you can and only use them for that particular purpose, so that if you did have an incident, it's very localized. That's the approach really that we have to take.
Okay. Thank you, Andy. I think we are getting there. So I think let me just quickly read the last question from Stephen. It says we are a council. We have council, or we are council had social workers who resisted moving digital. The solution was to make digital look like paper. Perhaps that also works the other way around. Say a digital news look like the paper one. So what can you say about that?
I think that's the one we just talked about, that I just talked about just now, Kay, where I was saying, actually, is there a opportunity to kind of reverse engineer the digital solution so that we have a paper version that's familiar for the member of staff in an outage scenario? I think that's an interesting.
Oh, okay.
That's similar as we just talked about, isn't it? Yeah.
Then Chris, do you want to talk, or should I read your question? Would you like to just speak out? Chris Goodings? Yes, please.
Yeah. Yeah, thank you. Good evening, Andy, and thank you. So this wasn't really so much a question, it was more like a bit of an observation that was building on from Amit and from Stephen's points about localizing some of the infrastructure more to like a ward level. So you'd have local storage on the ward level that would then pull to the central hospital database, and the central hospital database can pull from the NHS spine, and it's kind of like that cascading down of information and passing those records across. So in the event of an outage, from the central perspective, you've got more local copies available to you, and I think I mentioned this earlier on with having the data records contained on the devices. So a ward nurse, for example, isn't going to need to see the patients on, if they're in, say, acute medical, they're not going to need to see the patient records for somebody in surgical, and unless they're required to treat the opposite side of the ward. Wards are usually, because I trained as a nurse, the wards are usually split off into different sides. So you would be on you'd have your side. So that, in terms of downloading the data, initially you'd only need your patients and the patients that are assigned to you. As a ward sister charge nurse, they would probably need access to the patient records for the entire ward, and if that nurse moved across to treat another patient, they would then be able to drag the records across and then they'd have access to them. Similarly, if you've got a nurse going around doing drug rounds, then they're only going to need to see the patients to which they're assigned to, and if they need to see the records for the other patients, they'd have them available. And then in using those sort of virtual networks, the VNets and the VLANs to sort of narrow down the sort of security domain as well, so you could keep things a lot more sort of controlled. I think was in that, but it was more of an observation than a question. I don't know your thoughts.
Yeah, no, those are the types of things we're looking at. So yeah, you're absolutely right track. I think the challenge is how fast moving things can be. So that kind of works okay if you're in like an elective ward. As you say, you've trained as a nurse, you'll know the difference. It's much slower paced. If you go into our emergency department or our emergency floor and look at how fast people get moved around, you could take a snapshot of where everyone is, and then 5 minutes later you've moved 10 patients, and then you've got to kind of work out whose patients are whose all over again. So those are the types of challenge we've got. Is it worth trying to segment it, or do you just need everything to be synced everywhere and then try and manage who's got access to what? These are exactly the types of conversations that we're having on it. So no, you're on the right track.
Yeah. In my mind, I've got this idea of this sort of somebody with a tablet, and then they're just dragging and dropping patients. Patients are like in a very sort of visual interface, and dragging and dropping them to where they need to be. Very sort of
which is what we have that's what we have in the business as usual system, right? So what we're then talking about is how much of a parallel system do we create in case we have a problem with the core system, and again, what do you need? What's the basic capability that you need to be able to continue to function? Because it's not enough to say here's a list of all your patients and here's their records. If you're in an emergency department, you need to know who's been seen, who's not been seen, how long have they been waiting, what's their risk score. Then you start getting into how much of that information needs to be provisioned in the emergency downtime system versus how much of it you've got in your core EHR. So that's exactly that balance that we have to try and strike. So well, actually, if I've got enough information about the patient to treat them safely. What is that? Well, it's what medication they had. Have they got any test results back? Have we ordered any tests for them? Or are we going to end up giving them another X-ray, which is, completely contradictory in terms of all the radiation guidelines? We don't know. We've X-rayed the patient and they can't tell us. There's all that kind of stuff that we have to build in. But yeah, it's the same. Those are the conversations that we're working through. Yeah.
It seems like a really funky sort of project. I'd love to get my teeth into it.
Great.
Thank you.
Thank you. There is this one concerning the Ministry of Defense, MOD. I think this one might be just to discuss generally. We have used Pando in secure messenger hosted on AWS London. It works in austere environment as well as fiber optics failure in the UK. So I think Shresh Diam Data, are you there? I think he just wants to know, is it good, maybe part of the question, is it good to have sensitive information on cloud, maybe AWS or Microsoft Azure, for example? Do you want to comment on that and the other part of the question?
So yeah, I think the Pando app thing, that's one of the things we've looked at previously around secure messaging. So yeah, there are options out there. And again, sometimes it's about having a diverse set of solutions. So and again, it's a bit what we said earlier, we're trying to consolidate and reduce complexity and reduce the number of platforms that we're trying to manage and give to our staff. But at times there's some value in diversity, because if you lose one, you might still have one of the others that can help fill the gap. So there is that tension to manage, I think, for us as well around, it'd be great if we just had one system that did everything, but at the same time, then you've got nothing if it doesn't work or something happens. So there is definitely some value in thinking carefully about the balance of different capabilities you've got if you lose one particular core bit of your application stack. I think in terms of is it secure to keep stuff in the cloud? I think we could probably all ask ourselves questions about that. Are we happy that our online banking stuff's in the cloud? Are we happy that any of our online shopping stuff is done in the cloud? Healthcare sometimes is looked at slightly differently, and sometimes that's for good reason, but often what we're trying to do isn't really any different to what everybody else is trying to do. We've got patient data as well as staff data to protect. If we're putting stuff in the cloud, clearly we've got to make sure it's secure and we've got the right protections in place, the same as if we had it on-prem in a data center in a hospital. So I think, yeah, you've got to be careful around security always, and make sure that you're following the guidance and you've got the right protection around it and you've got the right monitoring tools, etc. Is that any different if it's in the cloud in 2024 than if it's in a server on-prem? I'm not so sure it is, as long as you've got the right protection in place. So it's about being careful about what you put in where and how you're securing it in transit as well as at rest.
All right, thank you. I think it falls more on maybe individual preferences. I think the last, there's another question from Amit. Amit, over to you, please.
So yes, so when I was describing my suggestion, I think I may have, I think I think people may have misunderstood me to say that when I was saying that download of information onto the local device offline, I did not mean to download all of the patient's data, every single patient's data onto the local device. It's just the patient that you're working with. I just wanted to make sure that that people didn't misunderstand me. Sorry.
Okay, no, thanks. I mean, yeah, I think the challenge we have there is we don't have one member of staff for one patient, so it's the managing that, who's looking after who, is the challenge there. But no, I get your point.
Okay. I think it's just 4 minutes to 8 now, and I think we have exhausted, if not all the questions that have been posed in the chat. So if we just ask the participants here, is there anybody that still has any further questions, any bothering questions, any contribution, any insights, anything you might want to add? Anybody?
It was brilliant. Thank you. I found it very interesting, this presentation. this event. Thank you.
Thanks all for
Thank
your
you.
contribution. I think it was good, as I said, it was good to make that bit more of a conversation. So yeah, thank you all for listening, and thank you all for your questions. I think it was a good discussion.
Thank you, Andy, and thank you, guys.
Thanks, Andy.
Okay. Okay. So
Thanks, Kate.
finally, before we wrap up, I've provided a lot of information in the charts links. So this is this year's Leicester branch. So I've provided the link to the website, so you can go to the website. If you want to join to be a member, there's opportunity for you to do that. If you're a student, there's a free registration based on your university. And if there's any question you need to ask, feel free, you get the email address on the website. So please contact us. So we do meet for events like this once in a month, precisely second Thursday of the month. So all information are available on the website. Thank you once again for joining us tonight. For those of us joining us for the first time, we really appreciate your time. We hope to see you again next month. So Andy, thank you very much for your time.
Thank you.
In providing us with this insightful discussion and information. Thank you. And everybody, thank you very much for your time, and do have a nice day.